I think we are ready to begin. Can you folks hear me? Oh, good. Good morning, ladies and gentlemen. This morning session is a live transmission case from the National Heart Hospital of a patient with a severe coronary artery disease who is going to undergo angioplasty and stenting and investigation. With me today for this session is Dr. Andrew Ong from Westmead Hospital in Sydney, Australia. And Dr. Koh Tian Hai has chosen a very distinguished panel for this discussion. And they are from Indonesia, from Thailand, from India, from China, from Japan. Now I'd like to introduce the panelists first. Dr. Janko Honye, the Director of Cardiovascular Center in Kukuma Memorial Hospital, Kanagawa in Japan. Dr. Viraj Kalasuk Chawan, Central Chest Institute of Thailand, is an interventional cardiologist there. And Dr. Sunwa Nakamura, our old friend, yes, is Director of the New Tokyo Hospital and is also President of the Cardiovascular Center in the Chiba Prefecture in Japan. Our old friend, Dr. Sunario Suryanata, is the head of interventional cardiology at the National Cardiovascular Center or the Harapan Kita in Jakarta, Indonesia. And Dr. Chang Bien, I hope he's here or is coming soon, is the senior consultant cardiologist at Guangdong Hospital in China. And our moderator this morning will be Professor Fang Jianming, our senior consultant cardiologist at National Heart Center. So welcome all of you participants, and please do send in your queries, your questions into the chat box, and Dr. Pham will analyze and give it to one of our panelists or one of us to answer your questions as best as we can. Now, I want to quickly say that this is the maybe 21st or 23rd consecutive live transmission course that Professor Koh Tian Hai and his team have organized over the years in an unbroken fashion, in a most admirable way. And today we are going to be treated with more of these teaching educational cases that will be of great use to the people and the cardiologists and the doctors and the nurses in this part of the world, and probably also elsewhere in the world. So without further ado, I think we can go to the first case, or maybe only one case today in the lab. So if it's possible, we can go to the lab. Good morning, Tian Hai, and is it Chee and Nicholas?
Hello,
yeah, good.
Hey, good morning, Richard. Thank you very much.
It's a pleasure.
Yeah, Andrew, as well as the esteemed panelists from all over Asia. So it's great to have you guys here. This is the second day of our SingLIVE program online this year. And we have a very nice and interesting case for you. I have with me two of my young Turks. All will be able to showcase what we have. So maybe I can first ask Jonathan Yap, who is one of our consultant interventional cardiologists, to give the history.
Okay. Thank you, everyone. It's my pleasure to introduce this case to you. So our patient is a 72-year-old Chinese gentleman. He's got all three risk factors of diabetes, hypertension, and hyperlipidemia. Of note, he has a CKD stage 3 with a baseline creatinine of between 120 to 130, and he has some possible myelodysplastic syndrome. Okay, over to his cardiac history. He presented in 2007 with an inferior STEMI, and we stented his mid-RCA. And in June, just about 6-7 months ago, he came in for angina, and the cath performed showed a borderline left main with triple vessel disease. We stented the LAD from proximal to mid. Distal was very diffusely diseased, and it was just a probate, and we shall see in the angiogram images later. And there was medical therapy for the tight RCA lesions. He came in once again just a week back, for a non-STEMI. And when we cath him, it showed that the left main disease has progressed. The LD stents were patent. And maybe we can show the angio images. So if you guys can see, that's the RCA. And this was after we stented it. Before that, there was very tight mid to distal RCA lesions. Next. And on screen, this shows the tight left main disease extending to the ostial LAD, and very diffuse LAD disease that has been there for the last year or so. Next. Okay. Next. So some more images. This caudal view of the spider view can show the left main bifurcation very clearly. And we'll go through that later on the images. Next. Okay, so just in summary, his Euro score is 2.6%. He has a syntax score of 22. He was seen by our surgeons and deemed high risk. The LAD is diffusely diseased with stents there, so no good place to put a Lima graft. So he's here for PCI today. Of note, his Meran risk score for contrast nephropathy is 9. This gives him a 14% risk of CIN and a 0.1% risk of dialysis, assuming that we use about 100 mils of contrast. Next.
So I would like to pass the mic over to Tang to lead the discussion and the treatment of this case. So Tang, please.
Okay, thanks Prof Koh. So first off, it's a great honor to be here. I'd like to introduce the rest of the team. I'm actually just a pair of hands together with John. This is actually obviously the A team. Prof Koh is here. We have Sister Tina. We have Edwin, who's the head radiographer here. And we have Nisa, who is helping us with the IVUS and all the other important bits that I have no idea about. So let us go through the images. We only took 2 shots this morning, mainly because of the concern of with regards to his renal function. So can you see the angio this morning?
Yes, we can. It's very clear. Thank you.
Hey, hi Andrew. How are you?
Hi. How are you? Good,
So
thanks.
yeah, so we've got the spider view, I think, on the right side on the main, and you can see that the left main definitely has a very severe narrowing, but you can also appreciate that this extends mainly into the LAD, and there is a based on the angiography, we're not sure how much the previous LAD stent extends to the ostium, and also in certain frames, you can probably appreciate that perhaps the ostial circ is also involved. And that would be right before that kind of small aneurysm, that bulge there. Well, what do you think of the angio images?
Richard, you have to unmute.
Did we show the cranial views?
Cranial, yeah, we showed on the.
Yeah. Sorry, we are having some trouble. Oh, okay.
Do you think the little bulge is the sort of end point of ramus artery or ramus branch at all?
Yeah, that's a good point. So actually, we have angios for this gentleman up to from 2007. There is no branch there even as of 2007. So we think this is, we think it's just some form of aneurysmal formation. Actually, there is probably a degree of vessel ectasia in this gentleman, because when you look at his previous intervention, he had a lot of ectasia in the LAD and even in the RCA as well. So for some reason, his vessel wall tends to form these little bulges. Yeah. So maybe I could invite some comments with regards to strategy here.
Dr. Nakamura, would you like to start and tell us what you would plan for this left main, distal left main? I just want to ask one point that, you may consider, of course, strategy for double stenting after your IVUS or your interrogation.
Yes.
Or you may want to have a provisional stenting with the stenting definitely into the left main and LAD, and provisionally for CERT. But now with this sort of aneurysmal dilatation coming as it were from the CERT, I would think, or at the junction, that might sway us a little bit more into doing a double stenting. I will see what happens with the IVUS and the projection. Dr. Nakamura, would you like?
Okay, so first of all, so I am the friend of the European guy who insists, provisional stenting. Mainly, I want to do the single stenting crossover. And actually, in this case, very not so easy case, but operator is Koh Tian Hai. Maybe not so difficult. Anyway, we need to see. We want to see the imaging first, checking the condition of the left main, we can dilate or not completely, and also the condition of the sac. Of course, we have some distal stenosis already. We need to also fix. So first of all, maybe I think better to see the imaging of the left main.
Yeah.
And then maybe I guess we can do just a single stenting.
Okay.
Okay.
He
Yeah.
prefers,
So in interest of time, I'll
show. What would you say?
Okay.
Well, I agree with Dr. Nakamura. We probably end up with provisional and single stent left main LAD. Of course, IVUS will then tell us the result. But since this is the right coronary dominant, so the CERT is some sort of not a dominant vessel. And then the distal LAD, it seems to me, is quite significant. So we probably will manage the distal LAD.
Oh, good point.
Yeah. So maybe I'll just pick up on that. Yeah, maybe I'll just pick up on that point with regards to the distal LAD. You're right. Angiographically, it does look very tight. But having said that, because we've got the films from 2007, it is pretty much the same from 2007. And when he presented, and when he presented for his intervention about 6 months ago, our colleague did try to, treat that distal LAD. Very, very difficult. Very difficult. So we have decided to try and keep things, uncomplex. So we are probably going to leave that alone for today. We may revisit it at another time, but for today, our main target lesion is the left main. Yeah. So let us show you what we have done. As you've mentioned, we of course wired all the vessels. Not too difficult to wire the tight stenosis, but then the rest of the LAD is quite gritty actually. So a little bit of maneuvering there. So once we've got our wires in, we did our imaging. This is the IVUS catheter that went through actually quite smoothly. If you can see this, little bit of a jump, but otherwise not too bad. So let's show the IVUS from the LAD, please, the first run.
So I would like to invite Dr. Horne. I know she's in the panelist. She's one of the top world experts in IVUS. So maybe she can help us, give us some information on the IVUS.
Okay, thank you. Good morning, Dr. Hai and everybody.
Good morning, Dr. Horne. Yeah. Thank you.
And now we are coming from LAD to circumflex, and the circumflex wire is coming from almost 2-3 o'clock. And right now, unfortunately, the air bubble, because of air bubble, we cannot see the image clearly.
Can we play again? Play again. Yeah. We'll just play that again. Yeah.
Okay. Will we go to the lesion?
Sure.
Okay, so this is the previously stented lesion, and now the stent itself expansion looks pretty good. And where is the lesion? At least the ostium of circumflex looks very widely open, so that a single stent crossover from left LAD to left main looks okay. And the proximal left main looks fine.
Okay. Yeah. We also ran the IVUS from the SERP, so maybe we can show that. I think that's run 3. Yeah.
Okay. So the proximal circ looks okay. The air bubble again, and you flushed, and proximal circ looks fine. The lumen looks very nice, and probably from left main here, and you can see that the aneurysmal formation. I would say this is a true aneurysm. And of course, there is some plaque in left main, and the plaque in the circumflex side, but there is no continuous plaque from left main to circumflex. So again, the strategy basically is a crossover stenting from LAD to left main. Thank you.
So Dr. Honye, you don't think there's any plaque in the ostia of the circ?
Dr. Honey, is there a plaque? Is there a calcified plaque at the ostium of the circ?
I don't think so.
Okay, good. What is the size that you think would be suitable for LAD and for the left main if we were to put a stent?
Okay, so because of the difference in vessel size, I would say the 3.5 stent with deploying from a little bit lower pressure, and then pot in the left main.
What is the size of the distal left main or to the mid, you think? About 5, 5.5?
Maybe 5, 4.5 or 5. So from my view, I cannot measure, so probably 5.
Just for discussion,
pretty big. It's at least 5 or more.
Would you say that this sort of case here needs an IVUS? But if let's say this person has got no renal involvement that will limit our usage of contrast, would you think an OCT would be an alternative or not so good?
In my hospital, no OCT.
Okay. All right. That's interesting. No, the IVUS seem very nicely.
Have you saw the IVUS of the ostia, the distal left main? There seems to be somewhat like maybe about 180 degree of calcification, or at least very fibrotic plaque. Maybe Nisha, you can run the LAD one, the third one, is it?
This final one,
yeah. No. Go to the left main.
Can move.
Go some forward.
Yeah, here. Back a bit to the left.
Okay.
Yeah, somewhere around here.
I see.
Yeah. So what is your strategy?
Lumen itself, you think it's pretty open. So okay, you can use you can choose 4mm stent.
Yeah. So I mean, we think there is some calcium, but maybe not so bad. So we are going to try and crack it or modify it a bit more with some form of a scoring balloon. So rather than go ahead and do rotational atherectomy, I don't think we need rota in this case. Yeah. So actually, after the IVUS run, we had a 2.0 balloon. So we have dilated the. Let me show you. Yeah, we have just tested it and passed the 2.0 balloon quite nicely. So it it goes quite easily. And so now we plan to put in a 3.5mm Scoreflex scoring balloon to try and open up that distal left main and ostial circ. So I'll start doing that, and maybe you can continue with the discussion.
So we have a few choices with regards to plaque modifying balloons. Maybe we should ask Viraj, do you have a preference in the distal left main as to the type of plaque modifying balloon that you use?
Are you too far in?
Yes.
4, 6, 8, 10, 12.
I think in this IVUS, we can see that the calcium is about 180 degree, and the in the angiogram also we can see some calcified lesion, but it's quite deep. I think the calcium may be two component, but I will try the cutting balloon first. Maybe it can modify the more accurate the plaque in the about the 1/2 of the circumference than the other one. And in case that the cutting balloon can work, maybe I will go on with the bigger NC balloon to ensure the opening of the artery. I think in this case, the rotablator is not useful because the IVUS did not have a bias on the plaque. Yeah.
Dr. Tang,
Viraj,
what would you do?
Sorry, Viraj,
Yes.
when you say cutting balloon, you mean like the Wolverine? Is that what you mean by cutting balloon?
Yeah, I use maybe either Wolverine or the NSE because they have three
Okay.
cutting blade.
Yeah.
Compared to the scoring
Sure.
balloon, the Scoreflex, they have only 2.
Dr. Chang, your thoughts? What would you do with the cutting balloon, or would that be your strategy?
Dissection. Yeah, dissection.
Sorry, we're not hearing the audio. Is that just me or?
Yeah, I think the voice is we can increase the audio a bit, everybody. But I think the point is, I think either scoring or your cutting balloon both should be able to, increase, will improve the compliance there at the distal left main and proximal LAD. So far, it looks as if the lumen has increased quite substantially. What is your next
the
step?
balloon passed quite easily.
Do you want to do more balloon enlargement with NC balloons, or you're ready for stenting?
Yeah, we're passing the IVUS down just to have a look at and see
Again, all right, sure.
the results of the 3-5 scoring. Yeah, but I mean angiographically it seemed to expand pretty okay, and you can see from the last angio shot as well that there is already a bit of dissection there, so that indicates we have started to modify the lesion.
One of the questions that's been asked, I think, is why did you choose a Scoreflex? I mean, was there a special reason?
Yeah, I think we all agreed we wanted to do a bit of scoring or even cutting.
Sure.
A little bit of debate or discussion about the safety of using a cutting balloon with multiple wires there. We think we would have probably been okay, but we decided just to err a little bit on the non-controversial side, so we went with the Scoreflex. Yeah. So that looks quite okay to my unexpert eye. Dr. Honye, you have any comments?
Yes, the scoring effect worked quite nicely. I saw that the lumen itself looks pretty nicely open. And you created a bit dissection, so it's probably the stent expansion will be obtained pretty nicely, I guess.
So you are happy with us to implant a 4O stent from the left main into the proximal LAD?
I think, yes, I would think a 4O is good because I think the left main, the proximal is a 5.5 or 6, So I think you would have to be able to upsize with the balloon if you're using one long stent from the left main to the LAD. And the LAD is also quite a good size. Your guide, just eyeballing your guiding catheter is the 7 French, and your LAD is already quite big. So I think you can take 3.5 or 4.0 quite easily. What does
Okay.
Dr. Nakamura think? What size you think?
Stent size?
Yeah.
Stand back forward.
If the Koh Tian Hai decide 4.0, I always agree with him.
Very nice of you.
I must take my hat off to Dr. Now.
You already decide the length of the stent?
Yes.
Yeah, we did some IVUS pullback measurements just now by Jonathan. We think the lesion length is maybe about 20 from the LAD to the ostium of the left main. We intend to try and cover to the ostium. So we are planning for a 22 millimeters. This is the this is a 15 millimeter.
Or you prefer 28? I mean, you know, I would tend to err on the side of being longer to cover, you know, all the landing zones properly. But you had a better measurement there on the length, Chee, so we'll follow what you say. Somebody wanted to ask you why, what is the size of your scoring balloon, you know, your score flex balloon, and why did you choose that size? Or is there only one size?
Okay, we chose a 3.5 millimeter. They have a whole variety of sizes. It's a non-compliant balloon. So based really on the IVUS, we decided 3.5. We didn't feel we needed to go all the way to 4.0. The idea is not really just to get the full lumen size, but really to just modify the plaque. So 3.5 we thought was a good fit. Yeah.
Yeah, I think that.
Can I ask the
was very good.
Yeah. Yeah. So can I ask the panel? I mean, the Circ. Do we need to put a gel balloon there, or do you think this will be just a complex, just complicate matters a bit more, or shall we just implant a stent straight away, or?
I think it looks quite clear, and the angle of the Circ is almost like at 90 degrees. I don't think you will pinch it greatly or you compromise at all the flow. I will put a stent right across.
Sure. Okay. So I think Jonathan is just double checking the measurements.
Yeah, I think the line is good. We just stent now.
Yeah.
Okay.
We want to show you the IVUS so that we can show you the measurement, the length.
Okay, so
can you switch over to
So maybe I'll show you at bookmark 1. That's where the stent in the LED ends. Just click here. And then B2 is where where the ostium is. This is about 19. You can click on this one. So that's where the proximal LED stent starts. And this is where the ostium of the left main is. So we're getting about 18 to 19. So we thought that for safety, you know, we overlap a little bit more inside. So we're aiming for about 22.
Yeah, because that area actually has 2 layers of stents already from the previous intervention. So perhaps a little bit less metal would be good. Yeah. So okay, I think we're gonna go ahead and do that. So follow 22, please.
Then some discussion about the ramus arising just or the very high diagonal. What do you guys think? We have a wire in there, but I'm not so happy about stenting across the wire.
Yeah, shall we take out that wire before we implant the stent?
On the IVUS, I think it's the high diagonal arises in the stent itself.
Yes, I would take out that wire. I think the wire is not going to be of much value there when you're putting the stent.
Agree.
Any other opinions from the other?
May I ask that regarding to the high breathing risk of this patient, would you concerned about the kind of stent we choose?
Yeah, that's a great point. So as we already mentioned, he doesn't have really very bad counts, but he does have some a little bit of anemia. His HP is about 12. His platelets is a little bit lowish. There's some query about myelodysplastic syndrome. He's got a bit of renal impairment. So all in all, he probably just makes it to high bleeding risk criteria, and yeah, so that certainly played a part in our thinking, and so we have actually chosen a Resolute Onyx. So this is a 4022 Resolute Onyx. Shall we test? What do you think of our choice of stent, or do you think it's not important? Okay. So
Yeah,
I
think that is quite concerned about the long-term use of the DIPT. So in case of high bleeding risk, selection of the stent that have the evidence for the shorter DIPT may be better.
I think notwithstanding the fact that the platelet count is low,
needs to come out.
I think you can have DAPT for not just 1 month, 3 months, 6 months, because it's left main. I think it should be all right. I think the choice of the stent that has been mentioned, the main thing will be the stent that can expand differentially. That means in the LAD, you could have a 4-hole. In the left main, you can separately use a higher size balloon, 5-hole, so that the stent can accommodate differential diameters. I think that's the main thing. So any of the stents, I think at the moment, whether it's Onyx, whether it's Science, Sierra, or whether it's Boston Synergy Special One, I think they should be all acceptable. Depends on what you have and what you're comfortable with, I think.
Study, we have a lot of space, so we just need to catch the osteo.
I think come out your guider.
Yeah. This guider now is suddenly very fond.
That's good. You adjust the stance.
Yeah.
Adjust.
Oh,
Looking good now, guys.
Looks good.
Let's do
All
a
right.
spider.
What do you think of this? Spider?
yeah, it's
spider
close
views?
to the osteo. It's very close to the osteo.
And I think you think we overlap,
Okay.
Chee Tang?
Yeah, on the aerial caudal, I think we're definitely overlapped.
So more than enough length.
Yeah,
right?
and we are definitely
Okay.
no issue with that
You're-
section. So
You're overlapped, you've got the ostium, you've got your guide out, make
Yeah.
sure nothing has moved, and then I
Yeah.
think you've got the two good
yeah,
Okay.
yeah.
I
I don't think we
if
should
you
hang
start
around
work
here too
with
long.
Post 10, I think
Yeah,
should be
go
good.
ahead,
Yeah.
Cranial
Mark,
Back to
has your
aerial
stem come back more than you wanted to now?
Yeah,
So
yeah.
good.
On the spider now, it looks a bit. Yep,
It's come
agree,
back
agree.
more, it's come back 3 millimeters.
We just
Chee
deploy.
Tang.
Yeah.
Yeah, yes. Yep, agree.
Just a
Let me
little
get
bit.
that in a bit. Here.
So I think your areocaudal and your areocranial are great views.
Yeah, I think this
The LAS
Oh.
are great view.
is fine.
It's moving a bit now. Okay, here. Okay.
Yeah, let's go.
Yeah.
Okay, we're gonna go up here. Okay, that was deployed at nominal, which was 12 atmospheres. I think like Dr. Honye suggested not to go too high in the LED. I think that makes a lot of sense. And we can touch it up with the pot later. I'm going to bring it back a little bit to flare up the stent, proximal edge. Yep, okay, here. Go.
18.
Okay. Okay, down.
Watch your guide as you go in. Yeah.
Yep. I'm just trying to slide it over the balloon.
Don't slide it over. You got 2 wires down there, Chee Tang. You don't want to straddle the stent.
Yep. Understand.
You got 2 wires to pull your guide back.
Yep. Especially the circ wire is trapped, right? So.
Correct. Straddling, pull it back.
Yep.
So the major risk is the risk of causing longitudinal deformation. So sometimes I would put another wire into the coronary cuff so that the guider doesn't actually go inside.
Okay.
That's right, Prof. I think that's the correct technique, because when you have a second wire in the circumflex, you have the risk of your guide shortening the proximal edge of the stent.
Actually, we have another run through, right?
Yeah.
Yeah. Why don't you try and yeah. So I don't know. What do y'all think? Maybe I'll try and rewire the circ with the other run through wire that we just took out from the ramus from the high diagonal.
Should we take a look first?
Okay, sure.
Yeah.
Yeah. Let's take it.
Get a guide close enough. Okay.
Well, from this view, just looking at it, the circ looks all right. Yeah. The circ osseous looks good.
Yeah. I think we also have the expertise of Dr. Hornier, so maybe IVUS will be helpful. Chee Tang, what do you think?
Yeah. Okay. Yeah.
Sure.
Absolutely agree.
Should we re-IVUS? Yeah.
Re-IVUS now. Okay. Sure. I agree. This looks quite nice actually. This acute result.
Yeah, I'm so happy the ramus is okay.
Yeah. And now that aneurysm looks less aneurysmally.
Yeah, it's true. I thought this one. It does look at least the same or even smaller.
Yeah. Do you have any thoughts on the reason why he's having so many aneurysms? Because we can actually see the circ aneurysm developing over the years.
I think it's all
in addition to a lot of LAD aneurysm.
Yeah, this man has got very diffuse atheroma, coronary artery disease all over. So I think there'll be some areas that will have a bit of aneurysmal dilatation, a bit of post-stenotic dilatation, and features like that.
Okay. So,
so you see that
looks,
aphasia? Yeah.
In mid-LAD, you can see some aneurysmal formation and incomplete stent apposition from 2 to 3 o'clock. And again, malapposition at 9 o'clock. But today you didn't touch this lesion, of course. And then coming back proximally, and now you can see the new stent which was implanted today, and the stent expansion looks nice, although it has a deep calcium. And you can see the stent ostium circ looks pretty nice, although the stent is over the bifurcation. And coming back, left main. And again, the stent expansion looks very nice because you pull the balloon a little bit and inflate it with higher pressure. Oh, it looks nice. The stent positioning looks almost perfect.
If Dr. Honyi, you agree and you prove, then I think it's very good. IVUS.
So what do you think, Chee Tang? Do you think we need to recross the circumflex, or you think
I think
the panel? What does?
I think that's a good point. I mean, the circ does look wide open. Maybe it'll just be safer, more adequate, just to dilate the LAD and then do a good pot in the left main.
So the only reason why we want to cross, maybe you want to open up the circ, but it's a little bit controversial. We'd like to hear the panel's opinion about whether we should open up the.
I think the IVUS shows that the ostial circ is quite open. It's okay.
Dr. Nakamura, would you recross into the circumflex, or would you just take out the wire at this stage?
So actually, in this five years, we have a lot of the discussion about kissing or not kissing. So because of the everyone just want to do the kissing because of this is gel, but we have a lot of the data, and actually, even if we check the OCT, and then if we have a if we are lucky, maybe the link position, it's maybe I think half. So if you are lucky, the link position is okay, maybe we can do the perfect kissing. But if the link position is not good, maybe just we make deform the strut. So actually this possibility is, I think it's a 50-50. So maybe I think scientifically we don't need to do the kissing all the way. But actually depend on the ischemic condition. So currently in Japan, in my center, we check the FFR through the strut, the circumflex. And then if the FFR is okay, just leave it. If the FFR show the ischemia, we do some ballooning. This is the current stage of the Japan, especially in my center.
Thanks, Dr. Nakamura. Dr. Chang, China, what do you think? What would you do in this case?
It's a short balloon.
Just go nominal.
For me, I will be IVUS and have a look. I probably wouldn't do FFR or IFR because it looks very good. I think the IVUS is good. Then I probably would agree with anybody who wants to do a kissing balloon since it's the left main distal. It probably will do no harm. But whether it's absolutely necessary or not is another thing. We have about 5 minutes. Dr. Chang from China, are you here yet? Sorry, Dr. Changmin.
I like to see, yes, I'm here.
Oh, we don't see your photo. Thank you. Yeah.
I just lost your for a while. In my practice, I will use once the standard strategy. And then after that, I will revile the circumflex, just a ballooning and the osteon circumflex, and finally you apply the technique for the left main. So I will use very simple strategy for this kind of lesion.
Okay, Dr. Chang, in Guangzhou, would you do a kissing balloon here?
No, we never use a kissing balloon. We will deform the left main stent.
But not so high pressure.
Okay. I think this has been an excellent case. I'll ask Dr. Andrew Ong from Sydney to wrap up the case and make the final comments about this case. Andrew, please.
Thanks, Richard. We've got 4.5 minutes left. Chee Tang, do you want to summarize what you've done? And will you remove the wire before your final pot in the circumflex?
Yeah, good. So just to summarize, we had to make a very careful angiographic examination first before we did the case. And then we passed our wires down the LAD and the circ, did IVUS examination. Thankfully, the circ ostium was pretty okay. So that gave us the confidence to proceed with our provisional stent strategy. And based on the IVUS, we did some scoring atherectomy, scoring balloon atherectomy to optimize the lesion. And then we popped in a 4 by 22 millimeter resolute on stent because of some concerns with regards to prolonged DAPT. So we've actually just done a 4 non-compliant balloon dilatation in the LAD, and we are putting in a 4-5 now just to do the pot. And I think with regards to the question of whether or not to leave the SIRP wire there, I think I'm very comfortable with leaving the SIRP wire at the moment. We've already done a bit of optimization in the left main with the SIRP wire in situ. So I think we can just leave it there for the moment. Yeah.
So you
just
plan
make sure
to
we are
leave the
not
wire
too far
there in
down.
the final pot?
Yeah. What do you think?
as long as you keep your guide out of the way, I think that's fine. Just be careful with your guide, and if it's out of the way, then that's fine. Keep it far away from the ostium, from the stent.
Yep.
Yeah, I see you guys going up. That looks really good.
Okay, go. So there's a 4-5. We toyed with the idea of 5-0, but Prof Koh always taught me that the enemy of good is perfect. So yeah.
Yeah.
I have to say it's an immense privilege now for us to scrub with Prof Koh. I haven't scrubbed with him for many years actually. He's just let me blunder my way around the cath lab. Yeah.
I haven't elbowed him enough.
Okay, go on. Yeah, I think they're definitely out.
Yeah. 16.
Well, we hope that Chee, you and the younger people will continue on the good tradition, in SingLIVE and the National Heart Center.
Thank you, thank you. I'm not in the category of the younger already, unfortunately. Yeah.
I think this is a very nice case. It demonstrates that if you can pass the IVUS down, that really gives you very good imaging, and it helps you plan your case. You demonstrated that you did not need road ablation because it wasn't indicated given the IVUS findings that Dr. Hornier taught us today. And you showed that with a scoring balloon, you could expand the lesion, and then that was followed by a stent. And you've shown us that adequate post dilatation of the LAD and the left main was very important. And I can see that you're going to give us a final IVUS before we close.
Yep. Yes. Final IVUS run. Well, final hopefully. So this is I think just after, just where we I think we should be coming into the to the new stented area. So we did go up with a 4-row non-compliant balloon. This, so it looks okay. Yeah.
Yeah, looks nice. And following part, the stent strut nicely opens at the ostium circumflex, so you can finish the case.
Yes. We did 4-5 here in the left main. Okay.
A little bit incomplete stent position. Just a little
bit at the bottom edge. Okay, not too bad. Yeah.
Okay, perfect, guys. I think we have to close in 10 seconds. I'd like to thank all the panelists for zooming in. Thank you, everyone, and thank you to my co-chairman Richard for leading the discussion. Thanks, Prof Koh and Chee Tang, for a lovely case.
Thank you, and thanks for all the panelists for dialing in. Thank you so much for your contribution.
Thank you. Bye-bye. See you soon.
Bye.
See you again.